طيب I think we waited it long enough. Let's start. السلام عليكم شباب، كيف حالكم؟ So again معكم عبد العزيز آل الشيخ. I'm one of the emergency physician of Jamaat Malik Saud. So we're gonna talk today about a pediatric emergency. It should not be a long lecture, inshallah. Should be hour and maybe a half or something around that. Let's start. So pediatric emergency. So there's always a general rules to approach pediatric patients. So children aren't small adults. They differ. They differ in their physiology. They differ in their immunology. They differ in their way they their body behave, and also the drugs. Drug dosing is the most common errors in pediatric emergency. So it has to be by weight and kilograms, and by patient size. And also their vital signs different by age. So you need to memorize this. So this is very important. مين اللي معنا على الخط؟ ماشي. Okay, so we stop that. So it's very important, and then we understand the vital signs. So basically, so age. So if it's less than a year, the respiratory rate is normally between 30 and 60, and their heart rate is normal between 100 and 160. So this table you have to memorize, guys. So you memorize at least اللي هو أول ثلاثة اللي 1 from less than 1, from 1 to 2, and from 2 to 5. You have to memorize this by heart. Then the blood pressure differs. So the first month of life, your expected systolic blood pressure is 60. And from 1 month to 12 months of life, it's 70 millimeter mercury. And from 1 to 10 years, your blood pressure will be 70 plus 2 times your age in years. So if let's say you're 8 years old, what's the expected systolic blood pressure? And I'm waiting for the chat. ده عمرك 8 سنين. What's the expected systolic blood pressure? كيف؟ يوسف 120. سو احسبها 8 ب2 كم؟ Yeah, so 86. Exactly. So 8 يعني 8 ب2 16 16 زائد 7 و 16 زائد 70 86. Yeah, exactly. So definitely a question gonna ask you about that, and the lowest systolic blood pressure for somebody in age. It's very important to understand and know in the pediatric population. Then we go to the evaluation of pediatric population. We have a sample history. So you have your signs and symptoms, your allergies, your medication, your past medical problem, last food and liquid, and event leading to injury or illness. You have to memorize this as a sample history. You have to take it. Then we have something we call اللي هو pediatric assessment triangle. And it depends on three parts of the triangle: appearance, work of breathing, circulation to skin. And I'll come to this one by one. So appearance. So appearance عندنا mnemonic. It's tickles. What it means tickles, you need to assess one of these five categories. The first important thing is tone. تبغى تشوف البيبي هل التون normal or he's floppy. If he's floppy, he's sick. معنى floppy إنه يعني he's hypotonic. So the tone is very important part. Interactive. Does the baby play with you? Look. Does the baby interact with his parent ولا lethargic كذا منسدح ونايم? He have a small bitch cry. So that's a sick baby. Consolability. If he's crying, can their family make the crying stop? Can he interact with his parents, or he looks in pain? Okay, then look and gaze. Usually the children, can they look at you? They can maintain eye-to-eye interactions. So if he cannot look and her gaze is his gaze is floppy and he looks upward and he looks sick, so that's one of the appearance that he's sick. Speech and cry, the last thing. So if his cry is strong, he can speak in words, or if his cry is muffled, all these are signs of sick or well-being child, and you have to assess this. So that's the first part of the triangle, is the appearance. We go through the tone. Is he interactive or not? Is he consolable or not? Does he can maintain a look and gaze of normal look and gaze, and his speech and cry? Then we start work of breathing. So from your experience in the chat, guys, what signs of respiratory distress in children? Let's see. Nice. Tachypnea, cyanosis. What else? Yeah, tachypnea. Tachycardia. Yeah, that's true. What else? What other signs you look in the baby? Nice. That's a good one. Difficulty with feeding. Yes. Yes. But there's also another signs. They usually use their accessory muscles, right? So what we called is sniffing position. What I mean by sniffing position, تعرفون ايش sniffing position? Yeah, so let me open the camera شوي دقيقة بس. I can't see myself. Okay. So sniffing position يقعد كده. His neck is extended. His neck is flexed and face is extended. That's how you open your airway. برضو we call it في برضو في tripod positioning. Tripod positioning is an ominous sign. So tripod إنه هو قاعد, he's sitting, his neck is flexed قدام and he's extended his face. هذا معناه إنه there's maybe an airway obstruction. He's almost gonna his airway is almost gonna collapse. So that's the open airway. هذا حتى الطريقة, that's the position we do to intubate patients. فالsniffing position, it's a sign that he knows and he understands and he's gonna collapse very soon. So you want to know what position, if the sniffing position is or tripod positioning is an ominous sign. Ominous sign means a very bad sign, and you should run if you see a patient on a sniffing position, because he's most likely going to collapse soon. Then we go to the quality and voice of the cry. Does he have stridor? Does he have hot potato voice? All of these. Grunting is when you see this part of the neck goes inside, so he's grunting. And طبعا الريتراكشن اللي هو intercostal retraction. So you're gonna see between his ribs when he breathes, you see the accessory muscles works, and you see clearly the rib defines, and then the intercostal retraction. So it's very important. Sniffing position and tripod position is also worse. Quality of voice and cry, stridor, grunting, and retractions. Then we go to circulation. So in circulation, you're going to look at the skin appearance, the capillary refill, and the blood pressure. So what's the most important between the three of them? You think, what's most important one of them in the circulation, you think? Yeah, I agree. يعني either skin or the capillary refill. They're both the same, but the most important thing is blood pressure. So I don't think blood pressure is important in children, because children usually compensate by tachycardia, and a low or hypotensive child is a very late sign of shock. So you should pick up shock in kids before. So what's important thing is they can peripherally vasoconstrict when they're in shock. So you're gonna feel the skin cold, okay, and you're gonna see sometimes the color of the skin. Also the capillary refill is very important one. If it's less than 2 seconds, in the peripherally he's okay. If it's more than 2 seconds, it's a very early sign of shock. So, but depending on a blood pressure for signs of shock in children is a mistake, and it's a very late sign. Okay, so that's the first part of our lecture. Is I want you to know what's the normal vital signs, general ideas on how to assess a child from the look, and we went through the triangle, the appearance, work of breathing, circulation into the skin. Then we understand how we can assess the child. We're gonna assess is he sick, or he's ill looking, or he looks fine. Apgar score, it's in neonates. It's not related to all children. So Apgar score is when a new firstborn baby when the baby gets born in the first minute or 10 and then the 10 minutes of life. After that, there's no rule for Apgar scoring and assessment of any children. Okay. So now we're going to speak about fever. So that's the most common presentation in children. Most common presentation to the emergency department, and almost accounts for 30% of outpatient visits in each year. So it's a common thing you're gonna see is fever. And how you assess it mainly depends on the age. So meningitis risk is decreased from 1% in the first month of life to less than 0.1%. And serious bacterial infection is around 12% in the first month of life. So any fever in the first month of life is very dangerous. And in this, the most common bacteremia in this age group, is E. coli or Streptococcus, group B Streptococcus, Listeria monocytogenes, Neisseria meningitis. All these are common in the first month. And most studies of febrile infants less than 3 months of child cite bacteria or sepsis around 2 to 3%. And it depends on the age, as I mentioned before. So, what the pathophysiology? Fever is the result of the body's thermostat being arrested by exogenous or endogenous pathogens. Infants and young children are thought to be increased risk of bacteria, their immature immune system. So their immunity is not perfect, especially the first 3 months of life, and they cannot do the T cell pathway. The T helper pathway is not mature, so they cannot mount immunoglobulin against these bacteria. So they're at very high risk of getting a serious bacterial infection. So the problem with history and physical examination are rarely helpful in these children, and you cannot exclude this serious bacterial infection by only symptoms or by examining the patient. So even if the baby looks well, he can have a serious bacterial infection. That's the moral of the story. The safest course, especially for the first month of life, is he gonna do full septic testing. مش معنى full septic testing. And I'm gonna do blood cultures. I'm gonna do urine culture. I'm gonna do an LP for meningitis. I'm gonna do maybe a chest X-ray if it's indicated. Okay, and I'm gonna start some antibiotics. The common thing at this age group is we give ampicillin and cefotaxime. Can we give ceftriaxone in the first month of life? So Abdulaziz said no. Do you know why? And Ahmed. So we cannot give ceftriaxone in the first month of life. You're right, guys. But anyone knows why? السبب. So ceftriaxone can displace the bilirubin from its protein binding in the body, and that can go to the brain and can cause damage to the brain. So we worry about ceftriaxone in the first month of life. That's why we don't give it. So the antibiotic of choice is going to be ampicillin or cefotaxime. So let's repeat this. The history and physical exams are really helpful. Even if the patient look like he have a viral illness and his nose congested, he have runny nose, you still gonna consider him as a serious bacterial infection if the fever is between 0 to 28 days of life, and he needs full sepsis, testing, admission, and empiric antibiotic treatment. And so that's the first group. So the first group from 0 to 28 days, that's what we're going to do. From 30 days to 90 days, there is a debate. So sometimes there's three clinical decision rules that helps you, or guidelines that helps you can say, but usually those patients depends on the age, depends. If it's less than 2 months, usually you do the same as the first month. If it's between 2 to 3 months, you can do selective. You can do just urine analysis and maybe blood culture. And if he looks well, you send him home and assess him the next day. But for the exam purpose, 30 to 90 days. So from 0 to 3 months, you're going to do a full septic workup. And so, but from 3 months to 36 months, the most common thing is viral illness, because we have, alhamdulillah, vaccination now. Before, it used to be a high incidence of serious bacterial infection, but now it's very low. It's maybe 1.1% after vaccination. So if the patient looks well and his fever is like, if he's in second day of fever, you'll tell him go home, and if fever persists after 2 or 3 days, to come back for reassessment. And also that's include from 3 years to adults life. So you're gonna deal with him on examination based. So this is غالبا الantibiotic choice. The most important thing is you need to remember neonates from 0 to 28 days. So your antibiotic choice is ampicillin and cefotaxime. And remember that we cannot use ceftriaxone. And this is an important thing. As we said, the common organism causing sepsis and meningitis, the first 2 months of life, we need to remember group B, Streptococcus, E. coli, and Listeria monocytogenes. Then this is shifted from 2 months to 5 years of old to Neisseria meningitis, Streptococcus pneumonia, and Haemophilus influenza. But we need to remember those as the causes. That we need to remember the first 2 months of life, the 3 organisms and the 3 months of life. Okay, so we went through how you assess the child, how the appearance, and we looked through the circulation, the triangle of circulation, the respiratory work, and how his appearance, the general appearance of the child. Then we went through the fever, and we understand it differs by age group and how you're gonna manage it. Then we're gonna go to upper airway infections and obstructions. So respiratory distress from an upper airway obstruction is a rare but potentially a catastrophic emergency in young children. Causes can be acute infectious process. That's what you would worry about. Congenital anomalies. We're not going to discuss that. And maybe a foreign body in the airway or esophagus that can press the heart. Sorry, give me 1 second. Sorry, guys. So as we said, so we have the causes may include acute infectious process, foreign body in the airway or esophagus. So how are you going to say it? You'd really onset and duration. If it's acute, if he never had a problem with the airway or it's chronic, it's been always there, but progressively worsening. Associated symptoms, does he have respiratory distress, fever? Does he look toxic? Is he drooling? Is he cyanoid? Is there any neck stiffness or torticollis? Progression with age. So does it worse with age? Is it worsening with croup or infection? Exacerbating factors like positioning, doesn't matter if he's supine or prone, does it go? Feeding abnormality or dysphagia. Does he choke with feeding? Sometimes, especially with congenital abnormalities. Any prior airway procedure? Was he intubated as a neonate? All these are important. Choking episode also is an indication of possible foreign body if it's before, if it happened before. So how are you going to examine them? The most important thing is vital signs. You want to assess respiration, you want to assess respiratory rate, heart rate, and signs of respiratory distress. And you want to indicate if increased work of breathing. Is there any retraction, as we said, grunting, stridor, wheezing? And observe all the characters of timing of stridor and symmetry and quality of breath of sound. And respiratory failure is defined by the presence of extreme distress, hyperventilation, or hyperventilation. So, there's different types of stridor. So there's a supraglottic nose, there's a glottic nose, and a subglottic nose, and the sounds are different between congenital and acquired. So you don't need to memorize this, but this is for your own knowledge. So all these are causes of stridor, mostly congenital. So we have the craniofacial abnormalities, especially with the syndromes. Okay, we can have the laryngomalacia as also a common congenital cause of stridor. Then we have one of the causes of stridor is croup. So it's a viral croup is responsible for most cases of stridor after neonatal period, and it's usually a benign self-limiting disease. It's rarely going to cause an airway obstruction, and it's very common. So it's usually common from ages of 6 months to 3 years of life, and with the peak can peak from 12 to the first 2 years of life. Croup is seasonal and happens in fall and early winter, and the inflammation and edema result from a viral invasion of the subglottic larynx and trachea around the cricoid cartilage. The cricoid cartilage lead to upper airway obstruction. So croup is diagnosed as clinical, so you don't need an X-ray, but sometimes there's an X-ray finding, and we call it stable sign. So you see مثلا this is your trachea. شفت العرض حقه فجأة يصير كنا أنبوبة كنا hourglass shape من هنا. So this is a stable sign. What you can have it. Usually they come with stridor, so you're gonna hear a stridor voice. So you should today go to YouTube and try to hear a stridor voice. And also sometimes زي ما قلنا X-ray can shows stable sign. Also they can have a very specific cough, which we call it barking cough, okay, and it's very common. So it's a very different sound of cough. نشوف إذا عندي let's open YouTube for a second. Now we try to find barking cough.
Hi, I'm Dr. Richard Honaker.
Do you hear ولا لا؟
You know your kids will get that barking cough sometimes. That's a scary cough. That brassy barking sounds like a seal. It's not necessarily a bad thing, but it is something you need to pay a little more attention to. It can be a signal of croup or bronchiolitis caused by a specific which is they start throwing up or
If your child has a loud barking, cough, fever, and noisy, high-pitched breathing, he or she may have a viral respiratory illness called croup.
Croup is a narrowing.
Dr. Jacob.
Allow the windpipe to relax.
Sorry, so I'm trying to find.
Hello, this is Dr. Carlo Ogier.
I cannot find it, so معلش, excuse me guys, but you have to look at YouTube and try to listen to the barking cough. It's very important. Once you listen for this and you memorize it that it was croup, you're never gonna forget it. So let's go to the treatment part of croup. Usually you want to place the patient on pulse oximetry and administer oxygen if he's hypoxic. You want to give them dexamethasone, and it's the main treatment is steroids. So you want to decrease the inflammation around the larynx to improve it, and you want to administer nebulize, sometimes racemic epinephrine. Okay, that may help. So this is very important table. So who is fit to be discharged? Who is fit to go home? Any at least 3 hours since the last epinephrine, racemic epinephrine. He's non-toxic. He looks well. He's able to feed and able to take fluid. And the caretaker is very important. He must be able to recognize if the child is the child doesn't look well. So if the caretaker is old, cannot recognize signs of sickness, or the baby doesn't look well, you may need to admit these. So it's very important table. So we have 4 things you need to remember. He at least 3 hours since the last racemic epinephrine. He does not look toxic. He looks well, able to take fluid, and able to take orally, and caretaker is able to recognize signs of sickness and can bring the child back. Then after that, so the first part of the upper airway infection is croup, and we discussed is a viral illness that can happen. X-ray, it's recognized by a barking cough on physical examination and a sound of stridor. We said sometimes on X-ray you can see the stable sign, and you treat it with Dexa and sometimes racemic epinephrine. And then we have the epiglottitis. So epiglottitis is a life-threatening infection that can occur at any age of life. In immunized children, usually it's caused by gram-positive organism. It's classically any sudden, abrupt onset of high fever, sore throat, and drooling. Because it's an upper airway problem, the patient cannot handle his secretion. So he cannot swallow his secretion. So he drools. And also a common exam thing is hot potato voice. His voice is different, and they call it hot potato voice, character of voice. So these symptoms rapidly progress to stridor and respiratory distress. This patient, you're gonna see him and patient usually appear toxic and assume زي ما قلنا tripod or sniffing position اللي هو ominous signs for airway obstruction. So as I said, whenever you see your patient is in tripoding or on sniffing position, you should be worried. You should run to that guy. طبعا diagnosis is clinical, so he looks ill, he's drooling, his voice is changed, he has stridor, he's tripoding, he's toxic looking guy. So that's how you assess him. And the lateral X-ray, that's we call it thumbprint sign. So you see this looks like a thumb here, معلش. So how are you going to manage these guys? So anticipation of airway loss. So you're worried about his airway is the primary importance of epiglottitis. So you want to prepare for emergent advanced airway management. So basically, you're going to call anesthesia, you're going to call ENT, you're going to call the general surgeon, and you all guys going to plan what to do with this guy. So sometimes you're going to watch him in the ICU with the airway kit beside, and everybody is worried and know about this patient. You want to keep the patient sedated and calm as much as possible. You want to give him oxygen and nebulize the racemic epinephrine to maybe decrease it. Also, after you manage the airway and make sure the airway is safe and secure, you can start IV antibiotic, IV line, and antibiotic. Sometimes, and also you can give prednisone to decrease the inflammation. Good. We're almost halfway to our lecture, so let's take 5 minutes break and we'll come back to you guys. Sounds okay? Okay, let's go back. So, Assalamu alaikum again. So we spoke about the upper airway diseases. قلنا Stridor, what can cause it, and we spoke about the croup and epiglottitis as a common and important causes of upper airway disease. Now we're gonna speak about wheezing and lower airway disease. And the three common causes of those is asthma, bronchitis, and pneumonia. So asthma is the most common chronic disease in childhood, the most frequently reason for pediatric hospitalization in North America. The primary pathophysiological pathway is an airway inflammation leading to airway obstruction and airway hyperresponsiveness. The most common triggers are sometimes allergens, irritant, and viral respiratory infections. So acute asthma exacerbation comprised of progressively worsening cough, wheezing, and shortness of breath, and chest tightness. Any exacerbation may progress to unresponsive asthma, status asthmaticus, and respiratory failure, and fatal asthma can happen. The quiet chest is an ominous sign of severely compromised ventilation and indicate airflow insufficient to generate wheezing. So ايش معناها؟ معناها if somebody looks sick and he's short of breath and you know he's asthmatic and you put your stethoscope in his chest and you don't hear wheezing, it's not the patient looks fine. It's most likely the patient in airway obstruction that he cannot move any air to generate wheezing, which is a really bad sign. So it's almost like pre-death sign. It's a silent chest sign. So the clinical elements of physical assessments include mental status, accessory muscle use, as we said, respiratory rate, and air entry and auscultation. So how are you going to manage a patient with asthma? So the most important thing, if his saturation less than 95%, you may give oxygen. Albuterol or Ventolin is a beta agonist and is the mainstream treatment, and it should be administered by MDI اللي هو زي القناع. We don't give a nebulizer البخار anymore because it's dispersed air everywhere and can cause, if the patient have respiratory illness, can cause respiratory illness to other or submitted, especially at COVID times. But we can give it through اللي هو MDI or اللي هو meter dosed inhaler اللي هو زي القناع أو زي الماسك. Aprotropium sometimes should be administered, and sometimes depends on the patient. Systemic steroids can be considered. So how are you going to treat them? Oxygen, beta agonist, albuterol or salbuterol, aprotropium, and also sometimes systemic steroids. Then we have bronchiolitis, which usually affects 20 to 30% of all of infants, and most frequently, and it's the most frequent lower respiratory tract infection in the first 2 years of life. RSV is the most common virus associated with this illness. You have to remember this information. RSV is the most common virus that associated with this illness. Young infants and those with history of prematurity, bronchopulmonary dysplasia, congenital heart diseases, or immunosuppression are increased risk of complicated disease. So what I mean by bronchiolitis is you have a viral infection. The virus going to produce a lot of, the baby going to produce a lot of secretion as part of the viral infection. So these secretion going to block your lower airway and gonna make your patient wheeze when you listen to him, and he's gonna be in respiratory distress. So the patient who cannot tolerate this virus are people with prematurity. So they're people زي اللي عندهم past medical history. So they're premature. They have a pulmonary disease, so bronchopulmonary dysplasia, or they have a heart disease. or they're immunosuppressed for any reason, there are more risk of complicated course of the disease. So طبعا the clinical features indicate a severity of illness, and maybe, so if you have dyspnea, cough, wheezing, that's a mild thing, sometimes goes to hypoxemia, accessory muscle use, and nasal flaring and poor feeding. So apnea and cyanosis or altered mental status are ominous signs, and those patients should not be discharged and should be admitted to the hospital. طبعا, as we said, infants are at risk of apnea, especially who's premature. So anyone who has witnessed apnea or his hemodynamically significant congenital heart disease should be admitted, as we mentioned. So how are you going to manage them? So unfortunately, it's mainly supportive. So nasal suctioning and saline drops is the most important thing. So the problem with these children is they obstruct their airway by secretion. So if you take out those secretion, you're gonna open their airway. So nasal suctioning and saline drops is the most important thing. Then you're gonna give oxygen. Sometimes those secretion gonna prevent the baby from drinking. He's not able to drink because in the first year of life, you have to breathe through your nose. You cannot breathe through your mouth as an adult. So if they drink, they can suffocate, and that's why they usually refrain from drinking when their airway is obstructed. So hydration should be assessed. So, and as we said, indication for hospitalization would include persistent hypoxia, is tachypneic or tachycardic, and inability to feed or maintain hydration. And anyone who's discharged with bronchiolitis should be seen within the next 24 hours. So we finished from the upper and lower respiratory diseases, and before we mentioned about fever and how you manage and how you assess a patient. Now we're gonna go to our fourth part of this lecture about gastroenteritis. So acute viral gastroenteritis is the most common cause of vomiting and diarrhea in children. Gastroenteritis is the presence, or diarrhea is the presence of three or more loose stool in the 24-hour period. So most infections are self-limited, but the most important thing is sometimes excessive water loss and electrolyte loss may result in dehydration, and that's how people die from gastroenteritis. So viral, parasitic, and bacterial pathogen can cause diseases by tissue invasion or sometimes alteration of the intestinal absorption of water and electrolyte. So either they invade the tissue of the intestine, or they can prevent the absorption of water and electrolyte, and it goes as diarrhea. Some bacterial pathogens such as E. coli, Vibrio cholera, or Shigella can cause diarrhea through the production of cytotoxins. So how are you going to evaluate any patient with a child with so the most important thing is you're going to evaluate the state of hydration. Is he hydrated? How dehydrated is he? Is he mild or minimal, moderate or severe? So the most important thing is skin, where we're going to feed. So skin turgor and tears. So when the patient, he cries and he cannot see tears, he's most likely moderately dehydrated. So this guy you're not going to send home. طبعا skin turgor, and نفتح الكاميرا again. So skin turgor is when you press on the skin, it goes back. You see? If you're dehydrated, the recoil can be slow. Usually in the moderate, it is less than 2 seconds. If he's severely dehydrated, it's gonna recoil more than it's gonna need more than 2 seconds to recoil. Also, you want to assess heart rate. Usually, if he's minimally dehydrated, his heart rate gonna be normal. But if it's moderate to severe, it's gonna increase. So these are important. The schedule is important, especially the skin turgor, as I mentioned, the tears, and the heart rate. Usually the blood pressure is not an important sign on these. So you want to assess, is the patient minimal, mild, or severely dehydrated to manage this patient. Also, you want to look for another clinical findings of such as bullous, so clinical finding for other than simple viral gastroenteritis. So sometimes bullous vomit or bloody vomit or hematochezia or abdominal pain or severe abdominal pain. You should think of other diagnoses other than viral gastroenteritis. Also, never forget to assess blood glucose in all patients and make sure that the vomiting and diarrhea doesn't cause hypoglycemia. Sometimes you want to obtain stool culture in children with high-risk features. So the high-risk feature would include more than 10 stool in the previous 24 hours, travel to high-risk area, fever in older age, and blood and mucus in the stool. And there's causes of diarrhea that may cause significant morbidity. That includes Salmonella, Shigella, and C. difficile. Some diarrhea can cause anatomical abnormalities that will lead to intussusception, toxic megacolon. Sometimes inflammatory bowel disease can look like it. So how are you going to manage these? So if it's a mild diarrhea or gastroenteritis, you want to continue the child with the preferred usual method of appropriate diet. So you can ask the parent if he drinks milk to continue drink milk in small amounts and assess him. If it's moderately dehydrated, sometimes you're going to give them oral rehydration therapy. Oral rehydration therapy, basically Gatorade sometimes. So it's water with glucose and salt. You want to aim for around 25 to 50 ml per kg over 1 to 2 hours. And you want to assess the patient in 1 or 2 hours. Sometimes if he's vomiting or if he's still vomiting, you can give him antiemetics like ondansetron and assess the patient if he's able to hydrate orally. If he's severely dehydrated, those patients should have an IV line. You're going to give them a bolus of 20 ml per kg of crystalloid, and then you can assess them after it. But those patients dies from dehydration, not the viral illness itself. So you need to make sure that they're able to tolerate PO fluids. That's the most important thing. And don't forget about other feature that triggers you that this is not a simple viral gastroenteritis like bullous or bloody vomitus, hematochezia, or abdominal pain. So finally, to the last part of our lecture today, it's going to be about diabetes. So we're going to speak about diabetes. Usually it's the most common endocrine disorder in the childhood. As many as 27% to 40% of new onset diabetes present as DK or diabetic ketoacidosis. We'll get and talk about diabetic ketoacidosis in a minute. So DK is the most common cause of death in diabetic patients under 24 years of age. So insulin-dependent diabetes mellitus is an autoimmune disease, as you know, and it is caused by the destruction of insulin-producing or beta cells in the pancreas. The lack of insulin and excessive glucose result in production of ketones bodies and free fatty acid. Those ketone bread is primarily beta hydroxybutyrate and acetoacetate. Acetoacetate is the cause of acidemia and change in your pH. So usually the classical symptoms of insulin-dependent diabetes mellitus include polyuria, polydipsia, and polyphagia, as we all know and remember. but sometimes the most common complaints would include weight loss, anorexia, abdominal discomfort, sometimes headache. Physical examination may reveal signs of dehydration, abdominal tenderness, and Kussmaul respiration if he's in DK. Kussmaul respiration is a sign of irregular breathing, so he's gonna take deep and shallow breath. And sometimes they can be altered if they're in DK. So it's very important to assess for the Kussmaul respiration, and remember it as it is a common question in exams about DK. So DK. So how are you going to define DK? So it's defined by the hyperglycemia, your blood glucose levels more than 250 milligrams per deciliter, presence of ketones and metabolic acidosis. You don't need to do a ketone test to assess for DK, but if your patient pH is if he's acidotic, pH is less than 7.2, and his bicarb is less than 15, and his glucose level is more than 250, or he's known to have if he's known insulin-dependent diabetes mellitus, you should think about DK. Sometimes you need other labs to help you manage those patients. So you need serum electrolyte, urine analysis, and venous blood gas analysis. So when you see a patient with diabetes, or you assume so sometimes, yeah, so what we're saying is sometimes laboratory tests required to diagnose and manage DK include serum electrolyte, urine analysis, and venous. So when you assess patient and you think he has DK, you need to look why the DK happened. So mainly, is it because of he's not taking his insulin? Is there infection that causes DK? And you need to look for the cause behind why the DK happened. That's one of the first management that happens. Then the treatment of DK is fluids. So you want to give them a lot of fluid, around 10 ml per kg or to 20 ml per kg. Then, so you want to start administering 10 to 20 ml per kg boluses until he's hemodynamically stable. Then you want to look for the potassium. So it's very important step. First step is 1, I'm going to give fluid around 10 to 20 ml per kg bolus. Second step is I'm going to look for the potassium and assess it. If the potassium level is less than 3.5, you need to replace it before your step 3. Step 3 is you're going to give insulin IV to the patient. Once the insulin is given, you're going to repeat glucose and VBG every 2 hours, glucose every 30 minutes because he's on insulin IV. And then you're going to shift to insulin subcutaneous once his acidosis improves. So let's repeat the treatment of DK as this the last thing in our lecture today. So the most important thing, first step is fluid. Your second step, which is most important thing, you can assess electrolyte. Electrolyte by assessing potassium. So if his potassium is fine, you're gonna start insulin drip, and you need to remember it's 0.1 unit per kg, the dose, IV, per kg per hour IV. And after that you're gonna shift to subcutaneous insulin. So basically, this is our lecture about pediatric emergencies, the most common emergencies we talk about. We talked about how you assess pediatric patient in the emergency department. Then we spoke about fever, how you manage fever, then upper and lower respiratory diseases, most common gastroenteritis we spoke about, and then the most common endocrine disorder in children. Do you have any question, guys? في أي سؤال؟ اوكي، يعطيكم العافية شباب. يلا good luck the rest of your course إن شاء الله and exam. بالتوفيق. يلا شكرا لكم. السلام عليكم.